So first we have Dr. Anju Kuriakose talking about fundus fluorescein angiography and ICG angiography.
Good morning to one and all present here. I am going to talk about FFA and ICG. So, what is FFA? It's a fluorescent angiography which involves photographic surveillance of passage of fluorescent dye through the retinal and choroidal circulation. So, to know about this, basically we should know the anatomy of retina and choroid. Retina and choroid has dual circulation, which involves most of the retina supplied by the central retinal artery and choroid by the posterior ciliary artery, and the drainage is through the otex veins. So next thing we want to be aware is blood retinal barrier. We have two blood retinal barriers, inner and outer blood retinal barriers, which have tight junctions. So when the basic principle of FFA involves. One second. So basic principle of FFA includes emission and absorption and emission. So the absorption occurs at the 465 to 490 nanometers and the emission occurs at 530 nanometers. The light is passed through the blue filter, and the excited light is emitted with the yellow-green light and recorded in the camera. There are 5 phases of angiogram. First is pre-retinal phase. Next is the arterial phase. Next is arteriovenous phase. Next is the venous and late venous phase. The first is the pre-arterial phase, where we will not see any dye perfusion. The next is the arterial phase, where we can see the dye perfusion through the arteries, mainly superior retinal artery and the inferior. Next is the mid-venous phase and the late venous phase. The technique is the camera involves 35 to 200 degrees of field. Sodium fluorescent water soluble orange dye is with low molecular weight is used. Most commonly used is 5 ml of 10% dye, and it is 70% protein bound and is excreted after 36 to 48 hours from urine. So this is the dye I'm talking about. It is a sodium fluorescent dye, water soluble orange color dye. So in the phases of the fluorescent angiography, first we will see about the foveal avascular zone, where the foveal area there is hypofluorescence. Dye is not seen in that area. What are the reasons for that is absence of blood vessels in the foveal avascular zone and blockage of background fluorescence by xanthophylls in fovea and RP cells in the fovea. This is the case of macular ischemia, where there is distortion and enlargement of the FAZ. So in interpretation of the fluorescent angiography, there is normal and abnormal. So in abnormal, we'll discuss more about the abnormal fluorescent angiography. There are two divisions, hyperfluorescence and hypofluorescence. In hyperfluorescence, there are 4 categories. First, it is leakage, pooling, staining, and window defect or transmission defects. Next is hypofluorescence, which includes filling defects and blocked fluorescence. There is one entity called as autofluorescence. It is the inherent property of a lesion to fluorescence spontaneously even in absence of dye molecules. It is commonly seen in optic nerve head drusen. Okay, you can see in this pictures, this is a normal fundus photo and this is the autofluorescence photo. Next is a hyperfluorescence, an area of abnormally high fluorescence due to the increased intensity of dye molecules. It includes leakage. Leakage is intensity of the dye increases with the size. As you see in the picture, this is the first image showing only the intensity, and the leakage and the size of the dye increases. Intensity and size of the lesion increases as we go to the later stage. It is commonly seen in NVs in PDR and CSR. This is smokestack appearance in CSR. Next is pooling. In this, the area of the leakage remains constant. Intensity of the leakage increases with time, but the area of the leakage remains constant. It is example serous PD in CSR. Next is staining. Staining is no change in intensity or size. Next is window defect. It is increased fluorescence in choroidal phase itself due to the atrophy of the RP cells. Next topic is after hyperfluorescence, it is hypofluorescence. It is area of abnormally poor fluorescence due to the paucity of dye molecules or due to masking of fluorescence. It can be either non-filling or blockage. This is non-filling, and next is blockage, which correspond. How do we differentiate it? Is we have to keep a fundus camera before that, and you can see the corresponding blocked fluorescence of this pre-retinal hemorrhage in the FFA. Now, what are the complications of FFAs? There are categorized into three: mild, moderate, and severe. Mild is staining of skin, sclera, and mucous membrane, stain, tears, saliva, orange, yellow urine, skin flushing. Next is moderate, includes nausea, vomiting, urticaria, fainting. Next is severe, which includes laryngeal edema, bronchospasm. Next topic is ICG. ICG was first performed in 1972 by Flower. Performed the first ICG to image the human choroid. So properties of this dye is, it is a water-soluble tricarbocyanate dye, absorbs light in the near infrared range of 780 nanometers and emits fluorescence at 820 nanometers. The importance of this dye is it is 98% protein bound. Infrared property allows the penetration through the melanin pigments and blood, and excreted through the through liver. So this is a basic principle of ICG. Phases of ICG. It includes early phase, mid phase, late phase, and the elimination phase. Abnormal hyperfluorescence are called as hotspots. There are of two types. One is plaque, which includes more than 1 dd size, which has more than 1 dd size, corresponds to occult CNVMs, and focal hotspots less than 1 dd corresponds to RAP and PCV. So how does an occult CNVM on ICG looks? Late stainage of the abnormal choroidal vessels, and ICG for ARMD to differentiate type 1 and PCV. So choroidal tumor to identify the dual circulation. We can see the dual circulation in picture C and D. What is the basic difference between this FFA and ICG? FFA is mainly for the retinal circulation, whereas ICG is for the choroidal circulation. Sodium fluorescent is used in FFA, which is 70% protein bound and visible in the light into visible spectrum. Low molecular weight and blue-green filter is used. For ICG, its choroidal circulation, indocyanine green is used, and 98% it is protein bound. Light of infrared spectrum, high molecular weight and infrared filters used. Advantages over FFAs: study of choroidal vasculature otherwise prevented by FFA due to RP blockage. Infrared is scattered less than visible light, so thus suitable for this media opacities. And ICG is 98% molecules are protein bound, so thus remain in the blood vessels for longer time. Thank you.
Thank you, Dr. Anju, for that very